A very good morning, everyone. I'm Dr. R. Bharadwaj, consultant endodontist practicing in Mysore, Karnataka. In today's Cynodent conference, I would like to enlighten upon a very crucial topic, that is traumatic injuries. Here we'll be concentrating on dental traumatic injuries, and the content goes as follows. I'll be speaking about root fractures, vertical root fractures, horizontal root fractures, cracked tooth syndrome, conclusion, and references. So, to begin with, tooth trauma has been and continues to be a very common occurrence that every dental profession must be prepared to assess and treat whenever there is necessity. It may leave not only physical scars, but it also leaves a psychological scar on the victim. It is coupled with the dynamic panorama of sporting activity worldwide and the significant increase in violence in our population. Tooth trauma and its management loom as a major challenge to the dental practitioner. So these are various etiological factors, like we have the battered tooth syndrome, any physical assaults or child abuse, and sports injuries. So these could be the etiological factors for such uh, dental traumatic injuries. So, how do you classify root fractures? Traditionally, according to the location of the root fracture, it is classified as apical, middle, and coronal third. And it could also be crestal bone at the level of crestal bone or subcrestal. And in these cases, there is lack of root length, especially of the coronal fragment. There is lack of bone, lack of pedial to retain the coronal fragment, and there is possible presence of bacteria. Typically, these bacteria communicate with the gingival sulcus and thus the entire oral cavity in general. This was given in Anderson et al. So basically, uh, fractures can be broadly classified as crown fracture, concussion, subluxation, extrusion, lateral luxation, and avulsion. So it could be hard tissue, that is dentin and cementum fracture, or soft tissue, that is dental pulp. Actually, depending on whether the coronal fracture has been displaced or not, it could also depend on that. The apical fragment is usually not affected by the injury, and all the forces of the impact have been absorbed at the fracture site, and the pulp's neurovascular bundle at the apical foramen will not be stretched. It will not be severe or it will not be harmed in such cases. And the pedial, the periodontal ligament space around the apical fragment will not be damaged. And the apical fragment is not displaced. So the pulp is usually normal in these cases. So you can have a look at here in this picture, the PDL at the fracture line, and observe the surrounding of the surrounding area of the coronal fragment. So that will be damaged whenever there is a root fracture, and the extent of the damage will vary at different levels of the root. And the region of fractures usually it poses some acute sort of inflammation. So basically, we have the apical the third of the root, middle third of the root, and coronal third of the root. That is further divided into subcrestal and supracrestal fractures. So basically, we have different types of healing in these root fractures. So we have a classification by Anderson et al., who states four different types of responses. So healing with hard dental tissues, healing with connective tissue, healing with bone and connective tissue, and no healing at all, where granulation tissue or the inflammatory tissue has already been formed in the fracture line, and as a result, there is pulp necrosis and infection of the pulp space, especially in the coronal fragment, which becomes infected. So healing with dental hard tissue, how it takes, it is the most ideal response. Here there is no displacement of the coronal fragment, only minimal displacement with good repositioning. Odontoblasts in the pulp, they have favorable conditions which produce reparative dentin to reunite the apical and coronal fragments. The dentin forms along the canal walls at the fracture line, and it is usually in a vertical manner rather than horizontal, and it is always in structure. It resembles a bone, a bony callus. The apical fragment remains normal, and the blood supply at the apical foramen is not affected. And the pulp canal calcification could be seen with over a period of time. It could be seen in both the fragments. And in a study where they found that 400 teeth with root fractures, they found that healing with hard tissue occurred in 30% of the teeth. And they were diagnosed within 6 weeks of the injury. Next comes your healing with connective tissue. It is more likely responds to a root fracture with the displacement of the coronal fragment. And the coronal fragment is usually repositioned and stabilized. Pulp may undergo repair by revascularization procedure, and some of the pulp may grow into the space of the fracture. Pedial cells are usually dominant contributor in these type of reactions. And in the study where I told you in the previous slide, 400 teeth with root fractures were noted, out of which 43% of the teeth healed with connective tissue inflammation. And these were diagnosed within 6 weeks of the injury. Then comes your healing with bone and connective tissue. So before the completion of the growth of the alveolar bone, this is seen in usually young patients. The coronal fragment, it erupts normally. As usual, the alveolar downgrowth occurs, and it is usually seen in 5% of the teeth. It's very rare. And a apical fragment remains in the position till it occupies uh, at the time of the injury. Next is no healing. The pulp of the coronal fragment becomes necrotic and infected. Here, 22% of the teeth are affected, where granulation tissue forms between the two fragments. Correct? And granulation tissue typically extends into the bone, which lies adjacent to the fracture line, giving the appearance of radiolucency extending laterally. So, lateral radiolucency is seen in such type of responses. Late pulp necrosis and infection, so it usually happens many years after the injury. Pulp initially survived the injury, but it continues to function until some event occurred, which allowed the ingression of the bacteria into the tooth system. It could be due to various reasons like restoration breaking down or an enamel infraction extending into the dent in periodontal tissue and the disease progression, so on. Correct? So what are the predictors of healing? First, the status of the pulp. So vital pulp and positive pulp sensibility at the time of injury are positively related to faster healing and hard tissue repair of the fracture. Age and stage of root development. Young age and immature root formation are increasingly related to pulpal healing and hard tissue formation at the fracture site. Why? Because of the increased size of the pulp and its vascularity. Mobility of the coronal fragment. Increased dislocation and mobility results in decreased prognosis and dislocation of the coronal fragment. And also various factors like diastasis, presence of restorations or margin periodontitis, whether it is middle third, which is considered to have the best prognostic value, and cervical is said to have the poorest prognostic value. What are the treatment factors? Forceful application of any splint will have negative influence upon healing. The type of splint also depends upon that, whether you are using a semi-rigid, rigid, or soft splint, which rigid splints often lead to poor results. Length of the splinting period. It is of not much significance. Usually 4 weeks is a normal thing. Treatment delay. Few days did not have a negative effect, but after that, yes, definitely it will have a significant influence on the healing process. Antibiotics. First, it does not improve healing. In fact, there is unexplained meta words which is surrounding this particular aspect, and there has been inverse relationship which has been found between inflammation, antibiotics, and healing. Correct? And the right side, I have put a table where it shows the type of injury and the splinting time which has been recommended in your textbooks. Coming over to horizontal root fractures, it is defined as fractures involving dentin, cementum, and the pulp. It is also called intra-alveolar root fracture. Correct? What is the classification? So it is usually depends on location of the fracture line, extension of the fracture line, number of fracture lines, and position of the coronal fragment. So location of the fracture line, it is cervical, middle, and apical. Extent, partial and total. Number of fracture line, simple and multiple. and position of the coronal fragment, displaced or not displaced. So depending on position of the fracture line, again it is divided into zone 1, which extends from the occlusal, as you can see in the picture, incisal edge to the alveolar bone crest. Zone 2, where it extends from the alveolar bone crest to 5 mm below it, and zone 3, where it extends from 5 mm below the alveolar bone crest to the apical end of the root. So diagnosis. So once you classified the root fracture, how do you come to the diagnosis? First is clinical examination. There could be displacement of the fractured coronal segment. It could be slightly extruded, or it could be displaced in a lingual direction. Check for clinical mobility of the tooth, and on palpation, you'll see whether tenderness is present over the root or not. Tooth might be tender, and there could be bleeding from the cervical gingival sulcus. If fracture is not apparent initially, it may become apparent over a period of days, weeks, and as it progresses, patient complains of sensitivity, especially when biting hard stuff. So it will be sensitive to biting pressure. Sensitivity testing may be negative initially. Radiographic examination, how will you examine? A root fracture will be normally will be visible when a central beam is directed with a max range of 15 to 20 degree, and occlusal radiographs can be taken. So you have to take two angulation radiographs, one increase angulation of 15 degree to the original, and second at a negative angulation of 15 degree to the original. But there is no significant difference between the sensitivity of digital radiography and conventional radiography to determine the root fracture. So what is the treatment plan? Whether it is apical, middle, or coronal, I'll tell you. Apical, watch and observe. If it is vital pulp, retain the segment. If it is necrose, surgical extraction. If the fracture is in the middle third, first reduce the fracture and stabilize it. So reduce the fracture and stabilize it. Then 70 to 80% of the intraalveolar fractures will start healing. Then pulp necrosis, you can go for root canal treatment. So cervical usually has the poorest chances of healing. So first is reduction and stabilization. The coronal segment is present, fracture below the alveolar bone crest. And in case of when do you go for reattachment procedures? When the coronal segment is present and the fracture is present at or above the alveolar bone crest. Post crowns, if it is absent and fracture is above the alveolar bone crest. Periodontal surgery, if sufficient root length is there, aesthetic result is not required, and fracture is above the alveolar bone crest. Orthodontic extrusion is done where the teeth have sufficient root length, aesthetic result is required, and fracture is below the alveolar bone crest. Surgical extrusion, where it is the emergency treatment of choice, and this is done in fractures below the alveolar bone crest. And you finally extract it when other conservative treatments are not possible and it has the poorest prognosis. So what is emergency management? Displacement of the coronal fragment. Check for the level of the root fracture. Coronal fragment, if it is avulsed, you perform the treatment same as avulsed teeth, which I'll be discussing later. Apical fragment does not require any specific treatment. Laterally luxation or extrusion, reposition it back into the socket. So how do you do the repositioning and splinting? So it is done when coronal fragment is not displaced and not mobile, so no splinting. If it is displaced or it is mobile, then sprint it. Use a simple splint, stainless steel vial which is bonded with composite resin. Fracture of labeled wall of the bone socket, stabilize the bony fragments. Rigid stabilization is most ideal conditions for healing with hard tissue, and traditionally the length of the time to splint is 2 to 3 months. 4 weeks if it is apical or middle third, and up to 4 months when the coronal third, especially when close to the cervical margin of the tooth. And root canal treatment must not be started as an emergency approach because the prognosis for pulp recovery is quite good in these cases. Antibiotics is not required, and a review. Do it after 4 weeks, 3 months, 12 months, then annual reviews of 5 years, and every 3 to 5 years thereafter you have to review the patients. Coming over to supracrustal root fractures. So the location of these fractures, it leaves a very short root with little or no medial attachment to the bone at all. The coronal fragment will be very mobile. More aggressive approach to managing supracrustal root fractures is usually required because pulp of both the fragments will be susceptible to bacterial ingression through these fracture line. So if the remaining root is not suitable for restoration, then it should be extracted. The site can be managed prosthetically with an osseointegration integrated implant. Crown lengthening can be done, orthodontic extrusion can be done, and restoration with a post-retained core and crown can be done. Root canal treatment, if needed, should be taken care of. Follow-up management, the main tissues to assess over a long period of time is the pulp, PDL, and gingiva. Pulp, you can always go for your cold and electric pulp sensitivity test. Assess your periapic radiographs very well, and especially the tissues adjacent to the fracture line. Look for any changes in the pulp canal. There could be pulp canal calcification in both your apical and coronal root fragments. Uh, Check for any favorable response. If any signs of radiolucency or resorption, start root canal immediately. Replacement resorption will start otherwise, followed by ankylosis. In such cases, extraction will be indicated at some point in time. Then your PDL. Check for the nature and degree of the displacement, which is a key factor. Check for the displacement of the coronal fragment because there could be a possibility of external inflammatory or external replacement resorption and ankylosis, which must be considered. And follow up with the periapical radiographs with percussion, palpation, and mobility test. Periodontal probing, especially in cases with coronal third fracture, maintains excellent oral hygiene. Premature loss of the tooth because of effectively short root, and infection of the root canal system could happen via these fracture line if sufficient gingival recession occurs, which makes a pathway for the bacteria to reach the fracture line. And root canal treatment only if required. Typical response, pulp canal calcification, not indication. First 3 to 4 months after the injury or many years later, it could be done. Only the coronal fragment. Then pulp in the apical fragment is usually unaffected and does not become necrotic. And you can obturate up to the fracture line depending on the extent of the fracture. So pulp necrosis becomes infected soon after the injury, and the actual size will depend on age of the patient, stage of the root development, and the type of necrosis. And foramen, remember, will be now at the level of the fracture line. So you have to be very careful. So use of calcium hydroxide dressing, placement of an artificial barrier such as your hard setting bioceramic material at the opening before filling the remaining part of the root canal with the conventional technique must be considered. So 1 or 2 extra appointments could be taken. Long-term calcium hydroxide leads to maximum antibacterial effect, action, which improves the treatment outcome. The artificial barrier technique, like calcium hydroxide, can be used as an intracanal medicament. So overall, the treatment time will be longer, but it will be very effective because it acts as a natural hard tissue barrier. And when you suggest orthodontic treatment of root fractured teeth, so it depends on the type of healing and the location of the fracture. So if the healing has occurred with calcified tissue, you treat it like a normal tone. If healed by connective tissue, then check for the location of the fracture and the length of the coronal fracture, which has to be evaluated. The root fracture in the middle third, the coronal portion is long enough to withstand the careful orthodontic movement, but thin labial part of the root can resolve and lead to significant shortening of root length. So root fracture in the coronal third, the coronal part is too short to ensure that there is enough periodontal support, and orthodontic treatment is therefore not indicated in such cases. Coming over to vertical root fracture and its management. Coming over to vertical root fractures and its management. So in this section, let us study what is vertical root fracture. So it is an untoward complication to root canal therapy which calls for immediate tooth extraction. It usually develops slowly, which is often unnoticed by the patient until there is enough clinical signs or symptoms to support it to make it apparent. In endodontically treated teeth, a VRF is a typical cause for extraction. So VRF is a fracture in the root whereby the fracture segments are incompletely separated according to American Association of Endodontists. So what is the prevalence? Prevalence of VRF leading to tooth extraction is not very well established, but they say there is a prevalence of 2 to 5% according to various retrospective radiological studies. Recently, a higher prevalence of VRF among extracted teeth has been reported, and in 2 studies on root-filled teeth, which were referred for extraction, 11% and 20% of them had VRF, that is vertically fractured teeth or root. Okay, what is the sequelae? So VRF occurs, it extends into the pedal space, communicates with the oral cavity, foreign substances enter the root canal, and there is bacterial ingression and failure. So patient complaints of sensitivity related to adjacent tooth or a given tooth. There is occasional swelling which is noted, sensitivity and mild discomfort while or severe discomfort while chewing. There is often long history of failing to diagnose the cause of the pain and discomfort. So a detailed history has to be taken, of which includes repeated clinical and radiographic examinations, which usually reveals the cause for the pain. So based on the separation of the fragments, we have complete and incomplete. Complete when total separation is visible or fragments can be moved independently. Incomplete when there is an absence of visible separation and these segments can easily be separated by an instrument. Based on the relative position of the fracture to the alveolar crest, it can be classified as supraosseous or intraosseous. Supraosseous, it terminates above the bone and does not create a periodontal defect. Intraosseous, it involves supporting bone and creates a periodontal defect. So what are the restorative treatment? Large restoration. So what are the factors? It is due to restorative treatment. The large restorations, forceful seating of crowns, intracoronal restorations like inlays, placement of pins which can cause stresses or wedging action causing root fracture. Parafunctional habits like bruxism, chewing eyes or abrasive footstep can also lead to vertical root fracture. Unexpected encounter with hard masticatory accidents, natural tight fossa cusp or fossa relationships, steep intercuspinations, and inappropriate choice of a tooth for a bridge abutment. Endodontic treatment, mechanical weakening of the tooth structure occurs during access cavity preparation, whereas clinic and shaping can lead to an increase in the chance of tooth fracture. Incidence of root fracture increases as the mesiodistal of the root decreases. So incidence increases as mediodistal diameter of the root decreases. Root canal obturation and post placement can also lead to root fractures, especially in the apical region. So use of screws and posts is another cause of fracture due to the wedging effect of these posts. Stresses from the cementation of posts due to hydrostatic pressure of cement are likely to cause relative deformation of the roots. And the volume of posts may expand in 3 dimensions, which as a result can deposit corrosional products on the surface. So how do you clinically examine? So we have, on visual examination, cracked restorations, there will be significant gaps between the old restoration or the tooth surface and extensive carious lesion, large failing occlusal restoration or wear facets on the teeth and restorations, presence of soft tissue swelling on the attached gingiva, which could be on the base or the entire tooth. Then the root fracture should be suspected if an apparently well-fitting post or core becomes dislodged. Biting test is usually done with a Berlioz disc or a tooth sleuth, and in percussion test, it may be done along the long axis of the tooth or angled against the labial surface or a cuspal or slope. Pain to selective percussion on specific tooth margins or cusp will be noticed. There will be generalized discomfort to percussion. So wedging and staining, methylene blue or erythrocin dye can be used, or a cotton wool stick which is moistened with dye is placed on the closure surface of a dry tooth. Patient is instructed to bite firmly on the stick and move the jaw from side to side. And excessive dye is wiped with 70% isopropyl alcohol. So trans illumination test is done through fiber optic light to detect the cracks. Surgical extrapolation, that is direct, which helps in direct visual inspection by surgical elevation of the flap, and it could be a reliable diagnostic approach. Periodontal examination, periodontal probing is a valuable tool. Isolated pockets are noted. Precipitous pockets are noted. Localized bone loss is seen. There will be presence of multiple sinus tract which does not heal over a period of time. And these pockets extend along the entire length of the fracture line. Probing depth on either side of the pocket will be within normal limits, but the probe will be very tight within the pockets and its movement will be from side to side, it will be restricted. And this is a pathognomic feature of a vertical root fracture. So what are the radiographic features? The recent radiographic techniques like CT and CBCT have provided better information. So you can see cement trails, which is a radioepic line which is visible in the treated root canal due to the flow of the GP, or a sealer into the fracture line when the fracture is in mesiodistal direction, correct? And when the plane of the fracture is in buccolingual direction, the excess cement material flows into the fracture and gives the appearance of second canal or an irregularly obturated root canal. So this is called cement drain. What is apical spaghetti? All of you like spaghetti. When there is separation of fragments which occurs during root filling, extension of the root filling material through the apex can result in the tangle of accessory points at the apex, which leads to widening of the pedial space around the whole length of the tooth. This is called apical spaghetti. Halo-like bone loss, which leads to J type of lesions, is usually seen in these conditions. Step-like bone defects, there is unexplained bifurcation bone loss. V-shaped radiolucency, which is confined to a single tooth or a root in the mouth. Resorption is always seen along the fracture line. Isolated bone loss can be seen. So there will be separation of the root fragments. Fracture line along the root or the root end fillings can also be seen, as you can see in the picture here. So the vertical root fractures should be suspected if the root filling appears well contained, but it is in very close contact with one wall of the root canal. Always note the space beside the post. Slight separation of the fracture fragment can result in appearance of a space between the edge of a root canal, which may be coated with cement and the post itself. It could be double image like appearance. So what is the differential diagnosis of VRF? It could be parietal groove, enamel projection, cemental tears, accessory canals, and teeth with necrotic pulp. So what are the treatment options? Variety of approaches are there. We can use cyanoacrylates, adhesive resin cement like 4-meta, reposition, and fixation with the wire, and mineral trioxide aggregate. So based on Luke-based categories, we have treatment plan 1A. If the restore the tooth with full coverage, temporary crown, and evaluate 3 months. If the patient is asymptomatic, permanent crown is cemented. If the pulp degenerates, plan 1B or treatment plan 2. What is this plan 1B? For incomplete supraosseous fractures, restore the tooth with full coverage stainless steel crowns, initiate calcium hydroxide therapy. Recall the patient at 3-month interval following 9 to 12 months of calcium hydroxide therapy. The bone level is unchanged, then endodontic therapy is performed and permanent crown is placed. If a pocket develops along the fracture, switch to treatment plan 2. For incomplete intraosseous fractures with non-viable pulp and a periodontal pocket which is seen along the fracture line, exploratory surgery is indicated. And if the fracture line stops short of the osseous defect, periodontal surgical procedure is required, which may be carried out to restore the defect. And depending on the status of the pulp, treatment plan 1A or 1B can be done. If the fracture line extends beyond the osseous defect, then treatment plan 3 is done. What is this? For complete intraosseous fractures with non-viable pulp, bone loss, and periodontal pocket, treatment plan 3 is done. So for single-rooted tooth, extraction. For multiple-rooted tooth, where fracture is confined to one tooth, you can either do root resection or root amputation, as we call it, or hemisection or extraction is indicated. What are the various materials which are there to bond the fracture segments? We can use cyanoacrylates as stated by Oliet et al., GIC by Troop and Rosenberg, and resin cement, which contains 4-meta or MMA by Sugaya et al. So these are the long-term studies which have been done and which further needs to be done to establish the prognosis and efficacy of the bonding and amount of periodontal healing which has occurred to achieve with such a procedure. So intraoral bonding of the fracture segment, in such cases, it has been noticed that sealing failed because of blood at the fracture site, which leads to persistent periodontal inflammation and in the already existing periodontal pocket. So it has therefore been suggested that intraoral bonding method might only be effective for fresh fractures and fractures with very little periodontal inflammation. So there was a case report where a vertical root fracture was noted with vertical bone loss in the integrated septum. Periodontal probe, which penetrated between fractured crown fragments, the fragments of the fractured tooth were extracted. Then biodegradable barrier membrane was GDR sort of membrane was placed, and after 4 years, the clinical appearance of the replanted tooth and the neighboring sentinel tooth with permanent restorations can be seen in the upper picture. The same radiographic findings after 4 years, where there is marked bone filling, can be observed in the periapical radiograph. So to summarize, for all enamel dentin fractures, an efficient dentinal seal is first important. In the case of crown root fractures, prognosis of the pulp is less good. The subgingival level of fracture makes all efficient bonding procedures, and thus the dentinal seal becomes extremely difficult or impossible. So maintaining the integrity of the pulp or pedial space or alveolar bone is the main criteria or concern in case of root fractures. So coming over to cracked tooth syndrome, cracked teeth are defined as incomplete fracture initiated from the crown which extends subgingivally, usually directed mesiodistally. The fracture may extend through either both the marginal ridges or through the proximal surfaces. And these fractures are located in the crown portion of the tooth. So this is a broad classification between crease lines, fractured cuff, cracked tooth, split tooth, and vertical root fracture. Please go through it. These are available in various textbooks, and mainly the crease lines are limited to enamel. Fractured cuff, you can see the crown, the cervical margin of the root. Cracked tooth, crown only, or crown to root extension with varying depth. Split tooth, crown and root extension to proximal surface. Vertical root fracture, only root. Okay. So conclusion, I would say that teeth with horizontal, oblique, or transverse root fractures have a very good long-term prognosis if the fracture is located in the apical or the middle third of the root, or if the fracture is located subcrestally in the coronal third of the root. Immediate repositioning, if displaced, and stabilization of the coronal fragments are very essential because it provides the best situation for healing. Prevention is a key to managing vertical root fractures. Comprehensive clinical, radiographic, and periodontal examination is imperative when evaluating any tooth which is planned for endodontic treatment or retreatment. And whenever a vertical root fracture is determined to be present, extraction of the affected tooth or root is recommended as soon as possible. So these were the previously asked questions, your 2-mark questions or your 10-mark questions. These are very important, especially the classification and the management part. Okay. So these are my references. Thank you and have a great day.